Hello, can you see my screen now?
Yes, perfect. You can put on slide share, then you can present.
All right. Not one fusion, just that. Okay. You see?
Yes, please go ahead.
All right. So good morning. Good morning, everyone. I'm Dr. Messi Gaza, Senior Registrar in the department. Today we'll be talking about body stalk anomaly. Presenting on a case we managed at Parenya this week. She was Miss TM, 22 years old. She was para or gravida 1. Sorry, I forgot to enter the last normal menstrual period, but she was 24 weeks. She was referred from Marconi 24-hour after presenting, no, sorry, she was 32 weeks. She was referred from Marconi 24-hour after presenting with premature pre-labor rupture of membranes, PPROM, for a day, and had been referred for an ultrasound scan from the local clinic. So when she went for a scan, that's when they diagnosed with the abdominal organs outside the abdominal wall. So at that time, they were working with a diagnosis of omphalocele, and they referred her here. So when she came, she had an ultrasound scan done by Dr. Verica, which confirmed those findings. She had an anterior abdominal wall defect, she had a thoracic wall defect, and we made a diagnosis of body stalk anomaly, and she was cancelled on the findings of the pregnancy. The history of note is that this was a planned pregnancy period, and in the first trimester period, she didn't use drugs in the first trimester. She had no family history. This pregnancy had actually not been screened. She had no COVID. Present on our findings on the ultrasound examination. But before I go further, I'll just talk a bit about body stalk anomaly. So it's a massively disfiguring, generally lethal malformation of the thorax. And an omphalocele, gastroschisis, pentalogy of Cantrell, oasis, which is omphalocele, exystrophy, spinal defects, and imperforate anus. So we'll just talk about our findings now. So this is an image showing the fetal biometry, the head circumference and biparietal diameter in this image. For these fetus, they were estimated fetal weight was just around the 3rd centile, it was, and then the biparietal diameter was normal. It was around the 5th centile. So as the head circumference. And so for this fetus, the head, the biometry for the head was normal. So was the transcerebellar diameter, it was normal in the head. No abnormalities were noted. This is another an image showing the fetal profile. The orbits were seen there, and as I said earlier, the head was normal. No abnormalities were noted on the head. Examination of the face. I have 2 images there. The one on the left shows the palate, which was normal. And then the other one shows the median profile, which was basically normal, where we can see there the frontal bones, we can see the nasal bone, we can see the jaw there, and it seems to be of a normal size. So the facial, the head and the face for this fetus were normal. And another fetal biometry examination, the femur length there, which was 53.9 and was less than 1%, which was now below which was abnormally short for that gestational age. And then the next image there shows the spine. In terms of the integrity of the spine, it seemed to be normal. There was no spina bifida. On the first image there, if you look closely, the skin is continuous above the spine. And on the second image on the right there, that one is taken at the level of the neck. You see again that there is continuity. There was no meningomyelocele. So the of the spine itself was not, but the curvature of the spine was abnormal. This child had kyphoscoliosis. In these images, unfortunately, they are all close-up images, so you can't really see the full length of the spine and how it curves. But when you look at this one, you find that there is a concavity that you can note, which under normal circumstances in a normally folded fetus in the uterus, the spine will be concave, but this image is will be convex really, but this image show a concave spine. So this shows that this fetus had kyphoscoliosis, which is one of the deformities that is found in body Stalk anomaly deformity. Now, this next image here is an image of the abdominal wall in transverse, in axial plane, which at that time, we tried to measure the abdominal circumference just to get a rough estimate of the fetal weight. And this was 264.56 centimeters, but then it was difficult to it at the appropriate level, given that defect, given that were distorted. But in this image, we can see the liver, we can see the kidneys, we can see the bladder there, and the cord was seen to be attaching outside the fetal abdominal wall. And then in this image, we see again an abdominal wall defect. If you look closely, you see that it's a full thickness defect involving the abdominal wall. At this level, we see the bladder there. it is filled with urine, and interrogating the blood supply with evidence of blood supply. And lower down, we also see the uterine arteries, the umbilical arteries, as they go around the bladder.
Dr. just a second, we'll ask
Yes.
the other guys to mute, if you could just mute your mics so that, because there are too many echoes. Dr. Madembo, Elves and Ghanese, if you could just mute your mics, that would help. Thank you. Yeah, please go ahead.
Thank you. So in this image, as I was saying, we're interrogating blood supply, and we can see blood supply to one kidney, and blood supply in one of the uterine arteries. No, sorry, the umbilical artery, as it goes around the bladder as the vesical artery. And in this image, again, we see the kidneys. So the outline of the kidneys, the left and right kidneys, they were very close together, low down in the pelvis. And there was a possibility that we could be dealing with a horseshoe kidney, especially if you look in both of these images, you see that the kidneys were right next to each other. So there was also a possibility that we could be dealing with horseshoe kidneys. Of note is that these abnormalities of the genital system, the urinary system, they are also common in these body stalk abnormalities and body wall defects. Another thing could also be the distortion due to the poor development and of the abdominal wall, as most of the organs are outside. But we queried, we thought that there might be a horseshoe kidney. This was an image again showing blood supply, tracing the umbilical arteries as they go around the bladder. And we could see one side of the artery. We didn't really see the other side, which also supports the presence of one umbilical artery in the fetus, which is also a common finding in body stalk. It shows again a full defect of the anterior abdominal wall. And at this level, we're now going towards the heart. And this image with color Dopplers there shows the heart there. And we can see that it is not completely covered in the thoracic cavity, but rather there is a defect, and we can see that the heart itself is in continuity with the outside of the abdomen. So there was a thoracic wall defect in this fetus. That is again another image, this one showing the abdominal organs. It was a close-up, so you might not be able to really see in relation with the rest of the fetal body, but it was just showing the abdominal organs as they were exposed. Another image near the level of the heart there. And in this picture, we see this was the level where we took the umbilical artery Dopplers. The umbilical artery itself was normal. And in the picture on the right, it's just showing a placenta, which was thickened here, 47.96 millimeters in its thickness, which was abnormal and thick. Because of the decreased amniotic fluid, it was also difficult to find loose parts of the cord where we could do the umbilical artery Dopplers. But again, this is not surprising, as in the body stalk anomaly, the cord may actually be very, very short, to the extent of that of being almost absent. It's recorded as usually less than 10 centimeters, and upon delivery, the fetus will be sort of stuck to the placenta because of that very short cord. So in we took the umbilical artery Dopplers next to the right at the point where they were inserting. Image of the heart closed normally in the but there is a defect there at the level of the heart, and that image showing the heart again and blood supply. This image is a close-up of the heart for trying to show the four-chamber view of the heart. And we could see the four chambers, we could see the valves, we could see the septum clearly. However, there was a concern, there was evidence of defects left that was showing, the one that is showing color Doppler flow there. There was a suspicion that there might be, both ventricles might be draining from one big vessel. There was concern that there might be either an overriding aorta or some abnormal drainage of the heart there, which again is common with the body stalk anomaly, where there will be cardiac defects. This was just a picture showing pleural effusion in the pleural cavity. So those are the imagery. So as Stalk Anomaly, I don't know if anybody will to just talk a bit about the other differentials.
Yeah, please go ahead, Dr. Gaza, then we can discuss at the end.
Okay, so this is just a table. We have, I think you can't read that. I'll just talk about, I mentioned some of the differentials already: an omphalocele, gastroschisis, umbilical hernia, pentalogy of Cantrell, body stalk anomaly, bladder extrophy, or OSIS, which is cloacal extrophy, omphalocele extrophy, bladder imperforate anus, and spinal defects. So to zone in on the body stalk anomaly, this is a rare occurrence whose incidence is from 0.3 to around 2 per 100,000 live births. However, this might be an underrepresentation because it doesn't take into consideration those fetuses that are miscarried naturally because of the deformity, and those whose pregnancies are terminated. In fact, in one hospital, there was a figure as high as 58 per 100,000 scans that it shown abnormalities of the anterior abdominal wall. So it is important, as we scan our patients, to offer them an early ultrasound scan, and also to examine the anterior abdominal wall to pick up some of these defects. The other defects, omphalocele, gastroschisis, those ones, they even bladder extrophy, those ones, they are compatible with life. But the complicated ones like the body stalk anomaly, they are incompatible with life. It's generally a lethal condition. So it's important to pick these early on, to counsel the women carefully, and discuss management options. In terms of location of the body wall defect, in our case, we may have differentials. Could it be a pentalogy of Cantrell? Because that again is got a body wall anomaly defect and cardiac defects. But that will usually be associated with a defect that is above the insertion of the umbilical cord. Whereas in our case, as we went down, we could also see that in the pelvis, the bladder was there, but the abdominal wall defect was present lower down. So that might rule out a pentalogy of Cantrell. But also the presence of the bladder would also rule out the OSs, because those ones are in those cases you don't visualize the bladder because there is excess trophy. So for this patient, we think she has a body stalk wall anomaly. We did cancel her on the findings, the ultrasound findings. We canceled her on the prognosis that it's a lethal condition where she is unlikely to go home with a baby. She was in the presence of her husband and their mother-in-law since they are a young couple. So at that time, she was also asking about options of continuing with the pregnancy, mostly because it's difficult to explain these abnormalities, even especially for a person, a lay person. They may not even visualize what we are talking about. They may also want to wait for delivery, hoping that the fetus will continue to grow and the defect will close. But as again, in all cases of fetal abnormalities diagnosed in utero, the counseling is the most important thing in FMU. You may find that you need more counseling sessions. A woman, you don't expect to get a decision, especially on the outcome of the pregnancy, within the first consultation when we meet the woman, but rather it's advisable to let them go, think about it, come back, and then a decision is made. So for her, when they left, they hadn't made a decision on the way forward with the pregnancy. But we did discuss the two main options, which are expectant management and termination of pregnancy. If she chooses expectant management, we've counseled her that this child is unlikely to live, or in the few cases where surgery has been done successfully, which is unlikely in our country anyway, it's expensive, there are long, multiple procedures, and the quality of life really is questioned. For some of the less serious deformities like bladder extrophy on its own, you find sexual life, quality of life, they will still be not good for those fetuses. So we have canceled her. We have booked a review. She's going to come for review in the coming week at Harare Hospital, where care will be taken further. She'll be cancelled. We'll discuss, and further management will be carried out. Thank you. Hello, that's all I have. Thank you.
Thank you so much, Dr. Gaza. We will open the room for questions, so people may unmute themselves and ask questions on the case. We are sorry, probably because of poor network, some people may have had challenges in joining, but I think we've gone through the case, room for questions. You may just unmute yourself and ask a question on the case. Thank you, Dr. Gaza. It's not an easy case to present. I know the images are not the easiest to read, but I think you managed to get them correct in most of them. So perfect. Good. So please go ahead and ask questions.
Thank you, Dr. Verenga.
Hello, Dr. Verenga.
Yes, please go ahead.
Okay, so I just wanted to confirm if the risk of chromosomal abnormalities or genetic disorders is increased in cases of body stock abnormalities. I was reading somewhere where they were saying that that risk is not increased because this condition is just spontaneous. So Dr. Gaza mentioned that the baby had one umbilical artery and it is associated with, it is commonly associated with babies with body stock anomalies. Can you say something on that?
You mean the...
Okay, maybe I'll just try.
Go ahead, Dr. Gaza, go ahead.
Okay, I'll just try before Dr. Verenga takes over. So yes, cases of body stock anomaly are sporadic occurrences. Few have been shown to have chromosomal anomalies. In the text that I was reading, only 2 cases had been reported. Most of them are just sporadic occurrences. So in of recurrence in our counseling, we may assure the woman. However, the other conditions that are in the whole spectrum of anterior wall defects, there are some that are associated with chromosomal defects, like umbilical on its own may be associated with aneuploidy. But if it's body stock anomaly, things like gastroschisis, they are just sporadic occurrences. I don't know if Dr. Verenga, I left anything.
No, I think you've answered it very well. So this is the same message we give to women that, look, the risk for chromosomal abnormality is not that increased, so that we do not offer these women invasive testing whenever they come with a body stock anomaly. So you are correct. The coexistence of a single umbilical is part of the associations, but just a single umbilical on its own does not change our decision in terms of its association with chromosomal abnormalities. So a single umbilical artery, if it is isolated, even in women who have been offered first trimester scan, if their risk is low and we pick up a single umbilical artery, we do not change the risk per se, because the risk does not change very much if the initial screening by the combined test or the fetal self-free DNA test was low risk. But what we have to do is a single umbilical artery is associated with abnormalities of the kidneys, the heart, and so forth. So a detailed anomaly scan, which will be looking at those organs carefully, has to be done in the setting of a single umbilical artery. So it does not change the message. It's actually part of the problem, or part of the associations of the body stock anomaly, a 2-vessel cord. I don't know if I've shared it, if I've answered it properly to you, Dr. Ndagura.
Sorry, Dr. Verenga, my network was down. I couldn't hear anything.
So we were saying it does not change the risk, Doc. The risk stays the same. It's a low risk. It's a low association with chromosomal abnormalities. So we don't offer invasive tests because we have seen a single umbilical artery. It's actually an association of this body stock abnormality.
Okay, that's fine.
Dr. Gaza, do you want to go to that table where you are seeing, just for learning purposes, where we are waiting for further questions? Just go to the table, slide number 23. Let me just use that slide to highlight certain issues.
Slide number 23.
Yes, where you are showing the other differential so that we clarify issues.
Okay, can you see it now?
Yes, I think everyone can.
Unfortunately,
Don't worry,
yeah.
Dr. Gaza,
Okay.
because people are looking on the computers because it's screen sharing, so they can read this. So,
Oh, okay.
yeah, let me just go through them. So, first of all, omphalocele, it is important to realize that the membrane is covering and the heart is inside the chest and the bladder should be visible. We're saying, how are we going to distinguish? Because the scan came to us, they were making a diagnosis of omphalocele throughout the way. And I think at some point, I don't know if some made a diagnosis of gastroschisis, but they were making a diagnosis of omphalocele. But we want you guys to be more cleverer, to realize that in an omphalocele, the heart is still in the chest, the bladder is still in the pelvis. And there is a membrane covering the organs, and the umbilical cord is inserted at the apex of the defect or the mass that is coming out of the abdomen, so that you don't misinterpret it as an omphalocele. Because an omphalocele and a body stalk anomaly, the discussion is totally different. And the outcome of this baby is totally different. Omphalocele babies leave, go to Harare neonatal surgical unit, you are going to see a lot of omphalocele any day you go there, showing that it's not a lethal condition. So in other words, at a fetal medicine level, you should not mistake an omphalocele for a body stalk anomaly, because it's a totally different disease in terms of the counseling and the reassurance of the mother. Because you can, if the diagnosis of omphalocele was to be retained, there's no way we can tell the mother that your baby is not going to walk in first street with the others. But a body stalk, we know that it's not going to walk in first street with the others, because the defect is so much and it's so disfiguring, and the heart is outside. There's no one walking in the street with a heart which is outside. Right. Then gastroschisis. In gastroschisis, is the bowels which are floating in the abdomen, in the uterine cavity, within the amniotic fluid, right? And there is nothing covering these bowels. They are not covered, they're just floating in there. The heart is still in the chest and the bladder is still in its place. So we should not mistake a gastroschisis for a body stalk again. Then, of course, umbilical hernia. This is a defect of the linear alba, but normally it's just a slight bulge that occurs at the cord incision. I'll show you the images for screening just now. Then the pendology of Cantrell. One thing that distinguishes pendology from body stalk is that you have this nice omphalocele which will be there, and the heart, you may have what you call ectopia cordis, where the heart is outside, just like in our case. However, the bladder will still be in its place. Will not be in its place, but we'll have what you call bladder extrophy. Bladder extrophy, that means we are not going to visualize the bladder when you go to the image which we use to visualize the bladder, because there is bladder extrophy. So if we miss the bladder, the heart is outside, we have this omphalocele, then it's more likely to be pendology of Cantrell than body stalk. Then body stalk is everything outside, as you saw in our case. Then bladder extrophy, the bladder should always be visualized. If we don't visualize the bladder, then the diagnosis of bladder extrophy is likely. Some may wonder, why am I emphasizing this? Because missing any of these abnormalities when you are scanning is a disaster for the parents, especially bladder extrophy. Bladder extrophy normally is more common in girls. These girls will probably be leaking urine for the rest of their life. It's not a lethal condition, but they'll be leaking urine for the rest of their lives. It's a disfiguring even with repair, so that they will never know peace and happiness, this baby. So couples will always have to be told in advance so that they can choose whether they would want a baby with that kind of life or not. So bladder extrophy should not be missed. Cloacal extrophy is a little bit more disfiguring than bladder extrophy. Of course, we have a nice omphalocele, the heart is in the chest, but with a bladder extrophy and the spinal defect, and an perforated anus, which is not easy to diagnose in uterus. But if we don't see the bladder and you see spinal defect in umbilical and the rest of the chest is fine, then it will be more of a cloacal extrophy. It's another disfiguring condition to have. So this is what I want us to understand. Dr. Zaga, if you could just come out, leave the meeting and give me the host so that I can just share some few images, then you can turn on again. You can just leave the meeting, give me the worship.
Okay.
Yeah, just give me the worship to just share 1 or 2 images that I want us to be very careful whenever we look at babies.
Oh, let me see if I can do that easily.
Yeah, you can do it. You can do it easily. Just leave the meeting. When you leave the meeting, you give me the hostship, then I can take it from there.
Help me leave the meeting. Okay. If I end, won't I end this meeting for everyone?
I don't know, just end for yourself. End for yourself, then assign me Fetal Foundation, assign Fetal Foundation the host. Then I just want to show images for screening for these conditions.
Okay, let me see.
Just be patient, guys. I think by 9 o'clock.
Okay, that's fine.
When you end, it will ask you to assign the host. Just go to Fetal Medicine Foundation, then you assign. Are you able to do that?
Okay.
Great. So you can join in later. You can join in now. So while she's joining, let me just show the images that we should all do whenever we do a scan. Remember, we are a fetal medicine unit. We're not screening, we are diagnosing. So there are certain conditions that we should never miss if you are scanning with us. This is why we want everyone to attend the meeting. Some people may not understand, why do I have to attend the meeting? We are at the top level of practice, and at the top level of practice, you continue to learn and to improve yourself. If you don't want to learn and improve yourself, then you cannot work with us, because you'll be missing umbilicals, you'll be missing body Stalk Anomaly, and you miss bladder extrophy, which is a disaster for the patients and also for our practice. So whenever you are doing abdominal circumference, when you go down, you are going to see, I think some people need to mute themselves a little bit. If you could, who needs to mute? Dr. Gaza, do you want to mute yourself? If you could mute yourself there. Dr. Gaza, please mute yourself. Thank you. So I think my screen is now clear there. If you look at this image, we always want to see this condensation where you see these 3 lines. It is very, very important to show these 3 lines on every baby, because this is how you screen for the anterior abdominal wall defects, number 1. If you are able to get this image as we see it here, and probably as we see it on the next image, probably this one is, yeah, the next image, look at how nice and clear this is. So you should always try to obtain this kind of an image. As long as you obtain this kind of an image, you have ruled out umbilicals, you have ruled out gastroschisis, you have also ruled out body Stalk anomaly. By obtaining this kind of an image in all your patients, the 3 lines where the cord is inserting onto the baby. This just show you in color there. Then the second image that you need to rule out again, this is more of 3 line, but showing a little bit of the blood. Let me go to the next one. This image, you again need this kind of an image to rule out all these other bad conditions like bladder extrophy, pentalogy of Cantrell, because in pentalogy of Cantrell and bladder extrophy, you are not going to see the bladder. The bladder will be missing at this plane, and you won't be seeing these vessels. There won't be a bladder in between them. the two umbilical arteries, there won't be a bladder. So for every patient that you scan, you should show this kind of an image so that you exclude bladder extrophy. Bladder extrophy should be excluded. We should never miss bladder extrophy, because bladder extrophy is a disaster for all the women who have it. If you have met a woman with bladder extrophy, you know what we are talking about. That is a total disaster and should never be missed antenatally. Then to show you again the images, that you need this kind of an image to exclude these catastrophic defects. This image can also be shown without color, where you show the bladder, probably like we see there. So these are all the images that you need to exclude most of the anterior abdominal wall defects, to make sure the anterior abdominal wall is continuous and nice, as we see it here, continuous and nice as shown there, and there is a nice condensation. So if everyone who scans babies decides that they are going to do an anterior abdominal wall the way we show it here, there is no way we are going to miss gastroschisis and diagnose them in third trimester, or exomphalos and diagnose them in third trimester, body stalk anomalies, cloacal extrophy, and pentalogy of Cantrell. We're not going to miss these kind of conditions. So yeah, so this is all you need to exclude this kind of conditions. Ectopia cord is rarely occurs as an isolated finding. It's normally associated with these other anterior abdominal wall defects. I think in a nutshell, this is what I wanted to share with us. I'll open the room for questions. If people want to ask that, any questions on what I've just shared with you there. Any questions, guys? If you have a question, you may unmute yourself and share and ask a question. So if you don't have any questions, thank you so much, Dr. Gaza, for presenting this case. So we will continue with our case presentations, and I think Dr. Zig next week will present other cases we have seen at Harare there at Salim Gabe FMU. So one thing which I want to emphasize is that we are a fetal medicine unit. We are a quaternary level. We are offering quaternary level care. At quaternary level care, we continue to learn. We continue to improve ourselves, so that I do not expect anyone who's scanning babies independently not to attend the meetings. Because if you miss a case of exomphalos, if you miss a case of cloacal extrophy, and if you miss a case of body stalk anomaly, it is not you who is going to be trashed. It is the fetal medicine unit which is going to be trashed. Because a fetal medicine unit should never miss this kind of cases. This is why we are having this educational course, so that we improve everyone who scans babies. So this is my way to you to say, if you are scanning with us, we expect you to attend these meetings so that you continue to learn and to improve, so that you don't put the name of the fetal medicine unit in disrepute. Because if you don't learn, you don't improve. So this is my expectation to everyone to say, guys, the learning season is here. Everyone has to learn. You have to continue to improve yourself. We want to arrive at the level that everyone else who scans babies in America and Europe is at. We are using the same machines that they are using in Europe. We have seen the international presentation. They use the S10, they use the E8, the E10. So there's nothing that stops you and me from doing exactly the same thing that they are doing. But the only way you can arrive there is to continuously learn. So this is my way to everyone, that we expect you to learn. If you don't want to learn, then at some point we see that you are not learning. If you don't change, then we'll ask you to say, look, let's find somebody who want to learn, who can work with us at your position, because we want to learn. So people who don't want to learn, unfortunately, I don't have good words for you to say, look, guys, we are learning people. We want to improve ourselves. We want to be where the rest of the world is. We are practicing fetal medicine here. There's nothing called fetal medicine for Africa. Fetal medicine is fetal medicine for the world. So the same kind of care that they are giving them in America, the same diagnosis that they are making in America, and in UK, in Australia, we need to make them and produce the same images that they are producing, because we are using the same machine they are using. There's nothing to stop us. So this is what we want everyone to do, to learn and to improve themselves, to become a better person than you were yesterday. So thank you very much, and let's continue the learning experience. If you come across cases, let those cases be shared. The Fetal group now, we want to probably to make it more of sharing interesting cases, because we may not be able to share all the cases that we see every week. But if you got some interesting images, make sure you anonymize the patient's details, please, before you share on the WhatsApp group. But let's use the WhatsApp group to share the nice images that we come across during the week, so that we improve each other. You can only improve your interpretation of images by seeing the abnormal conditions. It is only by seeing abnormal cases that you'll be able to recognize abnormal cases yourself. So let's begin to share images on the group and make comments on those images that are picked during the week, so that people continue to learn and to improve themselves. Thank you so much, and enjoy your Friday. Parenya, to see you soon. Bye-bye. The meeting has been recorded, so if you want the meeting, Fetal Medicine Foundation Zimbabwe will share it with you. Just send them your details, then they can share with you the meeting, because it has been recorded. Thank you.